Welcome everyone to today's webinar. It's a great pleasure to welcome today participants from all the continents with more than 140 people. This webinar will also be recorded and you can access it as all previous webinars under www.sarcoma.academy. We have a 45 minutes lecture followed by the discussion of the expert panel. Feel free to submit your questions during the talk and discussion using the respective button. Also, should you have any suggestions regarding format or topics, if you want to join the panel in the future, please do let us know. Last but not least, I'd like to thank you and our sponsors, PharmaMar, Bayer, Novartis, and Implantcast to support this webinar. Now it's my great pleasure to introduce Axel LeCesne from Gustave Roussy in Paris, who highlights the latest findings from this year's top meetings. Axel, please.
Many thanks, Bruno. Hi to everyone. It's always a pleasure to be with you, despite the fact you see my face too many times, but it's always a pleasure for me to. So today I just want to share with you different important topics discussed and presented during the last ASCO and ESMO 2001. Of course, it is a selection. I cannot in 1 hour give you all the resume of all different presentation, poster discussion, oral session, and so on. So I have made a nice selection of maybe presentation where we can modify our strategy in soft tissue sarcoma. The first of presentation is based on this paper. So the first presentation is made by Antoine Italiano from the French sarcoma group on the role of Antipediatric in some selected sarcoma overexpress tertiary lymphoid structure. I advise to you to read this beautiful paper on Nature in 2020. We can today have a new classification based on 5 sarcoma immune cluster based on the lymphocyte infiltration and based on the immunocheckpoint expression. So here on the left part in blue, it is the immune cluster A, which is clearly an immune desert. And in contrast, on the right part, it is so-called the hot soft tissue sarcoma, where there is a high lymphocyte infiltration, and particularly the tertiary lymphoid structure, and a high immune checkpoint expression. So there is clearly different immune cluster based on this lymphocyte infiltration. And when we make a correlation between one of the first trial testing an anti-PD-L1 pembrolizumab in the SARC-028 phase 2 trial, you see here on the right part, vast majority of response or benefit from immunotherapy are in the hot soft tissue sarcoma immune cluster. The 3 histological subtypes where there is a high lymphocyte infiltration is liposarcoma, leiomyosarcoma, and UPS. And some years ago, the French sarcoma group made a little phase 2 testing pembrolizumab plus oral cyclophosphamide in all different histological subtypes, absolutely not selected by any prognostic factors. And you see here we obtained only 1 response. The only one were tertiary lymphoid structure positive. All the other were negative. So the response rate was only 2.3% in this previous non-selected trial. And selecting the soft tissue sarcoma based on the tertiary lymphoid structure, you see here with exactly the same schedule, pembrolizumab plus oral cyclophosphamide, the rate of tumor shrinkage is more or less 50%, with 26.7% of PR. So it is clearly not a revolution, but selecting better our soft tissue sarcoma histotype based on TLS status. You see here is more or less 20% of all soft tissue sarcoma overexpress this structure. The response rate is higher than before, and maybe more benefit in frontline, and the benefit of immunotherapy decrease over time. I give you two examples of one partial response lasting 8 months in liver metastasis from liposarcoma, undifferentiated liposarcoma, and always ongoing partial response in an epithelioid sarcoma. You see here before and after. So it's something happened with this lymphoid structure, and when it's an historical comparison between the previous non-selected soft tissue sarcoma cohort and in this new study, you move from a median PFS from 1.4 months to 4.1 months. The first endpoint was reached. It's a 6 months non-progressive rate of 40% with this new study. So the discussion, and it was highlighted by the discussant at ASCO, first of all, that anti-tumor immune response in this soft tissue sarcoma may be mediated by antibodies produced by plasma cells. What is the next step? Randomized trial, maybe in first line versus what? The role of cyclophosphamide is debated. How to induce formation of TLS in soft tissue sarcomas that are not pre-programmed? Is it an accurate biomarker in advanced soft tissue sarcoma? A lot of questions remaining unsolved. There is also a beautiful presentation, not at ASCO, but at ESMO, trying to find biomarkers of response and also from hyperprogression on patients with sarcoma treated with checkpoint blockade. It is a pool analysis of the 5 larger trial testing an anti-PD-L1 on anti-PD-1. I think you're all aware on this paper, and it's interesting to see which kind of histological subtypes benefit the most from immunotherapy. It is UPS, of course, alveolar soft parts sarcoma, epithelioid soft tissue sarcoma, myxofibrosarcoma, and angiosarcoma. 16% achieve a CR and PR, and in contrast, 11% achieve a hyperprogression. There is more benefit in patients not heavily pretreated comparing to those who are having an hyperprogression. There is no difference between phenotypically or genotypically patient between a progressive disease or an hyperprogressive disease. It's unpredictable to see the patient having an hyperprogression. Another interesting thing in this paper is try to find characteristic of responders. And here on the left part, you see more you give an immunotherapy in first line or very few months after metastatic disease, and more the benefit is important. In contrast, when you give immunotherapy later on, in third line, fifth line, or after a long interval between the discovery of metastasis and the start of immunotherapy, and more you have PD and hyperprogressive disease. And another interesting thing, I discovered this article not a long time ago. It's interesting to see that the patient who benefits the most of immunotherapy is a patient with lymph nodes involvement. It is, one of example is the epithelioid sarcoma I share with you the slide before. So patient, there is 8 out of 18 patients responding to immunotherapy So it is clinically it's very easy to see lymph nodes involvement. So it could be a selection, an easy clinical selection for this patient. Another immunotherapy approach is adoptive immunotherapy, and Adaptimmune and GSK have two different approach, but based on T-card cell. Here it is the communication of Adaptimmune with the afami-cell. I think maybe you are aware on this T-card cell. Here is a T-cell lymphocyte with a T-cell receptor able to target solid tumor, and in this study targeting the expression of this protein, the MAGE-A4, which is highly expressed in synovial and in myxoid round cell liposarcoma in a context of major histocompatibility complex. So it's a nice approach. We have to make a high selection of this patient based on HLA screening and followed by MAGE-4 expression on immunohistochemistry, the leukapheresis, and then lymphodepletion by high-dose cyclophosphamide and fludarabine, and then reintroduction of SPEAR T-cell infusion. It is one shot. It's a complex trial because there is a high number. We need a high number of pre-selected patients. I give you an example on this study. 330 patients were screened with synovial sarcoma and myxoid liposarcoma. Half of them are HLA-A2 positive, and then these patients are screened for MAGE-A4, and 60% of these patients overexpress MAGE-A4, and 59 of patients have been included in the trial. At the time of presentation, only 37 receiving the T-cell treatment. So it means 37 out of 330. Well, now we have more patients in the trial, more or less 50. And the last presentation, the last update was presented in CTOS in the few days. And when you give a look to the response, it is only one shot. I remember you, it's only one shot. Here, high level of tumor shrinkage. There is 2 complete remission in patients with pre-treated synovial sarcoma, 41.4% of tumor response in terms of CHOI and RECIST criteria in synovial sarcoma, and 25% in myxoid round cell liposarcoma, or disease control rate of around 85%. So it's an active regimen. So today we can consider immunotherapy like the 5th pillar of sarcoma care in 2021. One of the objectives is obviously to find really biomarkers to find the optimal patient for treating with this approach in the future. Now, if we come back to conventional chemotherapy, this paper from the French sarcoma group, the LMS-04 study comparing in first-line and front-line chemotherapy regimen in uterine and non-uterine leiomyosarcoma, doxorubicin alone versus doxorubicin plus trabectedin, according to the results of phase 1 published years ago. We have already made in the French sarcoma group the LMS-02 study give very good results in this little phase 2 in leiomyosarcoma. So, but we stopped doxorubicin and trabectedin after 6 courses in this study, and this phase 3 study, the LMS-04, allowed to have a maintenance of trabectedin in case of tumor control after 6 courses of the combination. The expectation was to increase the median PFS from 3.7 months comparing doxo and the combination. And the results are impressive because the study has met the first endpoint, reached the first endpoint. We moved from 6.2 months of median PFS with doxo alone to 1 year with response rate 13% with doxo alone, 38% with a combination. Same results in both cohorts, uterine and non-uterine leiomyosarcoma. So there is an improvement in both arms, in both cohorts, with a combination of doxorubicin. Of note, 28% of patients receiving 17 maintenance cycles of trabectedin in the combination arm. Of course, the toxicity is more important in the combination in terms of febrile neutropenia, thrombocytopenia, transaminases elevation, of course, not surprisingly. 40% of patients progressing under doxorubicin receiving trabectedin in second line. And the study was not planned and not powerful to find a difference in overall survival. But the 6 months median PFS is also translate in a 6 months benefit in overall survival. The difference is not significant because there is confidence interval is more than 1 year, but it is limit. If we have included more than 150 patients, the overall survival can be significant in favor of doxorubicin. So it is a discussion today. Maybe we can have a discussion after my talk. Doxorubicin could become a new standard on metastatic leiomyosarcoma. Little phase 2, we are always in uterine leiomyosarcoma with a combination of olaparib and anti-PARP inhibitor plus temozolomide. It's a little phase 2 report in ASCO 2021 with interesting results. It is a little cohort of 22 patients, but it's an interesting approach to combine an PARP inhibitor and temozolomide at this dose. There is no clear biomarkers between DNA damage, gene mutation, and response, pending the methyl-guanyl methyltransferase methylation status for the temozolomide. So it's only to share with you this little phase 2, but it's another approach in uterine leiomyosarcoma. We move to desmoid tumor because there is at least 3 or 4 different presentations. I think you are all aware that today the best approach is to adopt a wait-and-see attitude when we discover desmoid tumor, aggressive fibromatosis, and Sylvie Morello have reported at ESMO one of our first prospective trial collecting all new cases of desmoid tumor between 2012 and 2015. Of course, the majority of female, not surprisingly, 34 years of median age, different presentation, vast majority is abdominal way, and we have find very interesting things. So all these patients are only, we have adopt only active surveillance. So when we have included this patient and we see the patient with a new MRI 2 months later, 4 months later, 6 months later, 9 months later, 1 year, and then after every 3 months, so without any treatment from the diagnosis until response or until progression. So only based on an active surveillance, you have 9% of complete remission, 22% of partial remission. So there are spontaneous response rate of around 30% of case. is the best response. Stable disease in 2/3 of patients and only progression in 2 patients. When you give a look to the spontaneous response, the time to achieve a PR from the beginning is 3 years, spontaneously. You can start to see a decrease of desmoid tumor after 9 months. In general, after surgery of for another disease, or you have a growing tumor, a growing desmoid tumor, and more you wait, more you see an inversion of the progression, and you can see the start of the diminution of the tumor after 9 months. So we have to be patient with this so-called benign tumor. So here it is the algorithm of this 100 patient. Give a look on the right part for the patient with stable or partial remission, around 50% of patients. 42 are always today in an active surveillance. 7 of these 49 patients receive chemotherapy or cryotherapy or even 1 surgery. In a context of stable disease of PR, so some patients want to make more, want more active treatment because psychologically maybe they cannot support residual mass, but it is a minority. And for the patient progressed over the time, we continue also active surveillance in 25 patients out of 48, and we propose hormonal treatment, chemotherapy, cryotherapy, or surgery and radiation therapy in only 4 and 1 patient. So it means after a median of 46 months of follow-up, less than 10% of patients receive radiation therapy or surgery. So it is a new, this controlled prospective study legitimizes active surveillance in frontline strategy, as is the case, and this is recommended in the new paper, in the new guidelines ESMO just published last year. So today it is clearly our standard here in Gustave Roussy. We followed all the patients and we treat only the patient where only the patient who progressed. After this study, we built another study named Altitude, and we have included 628 patients. And one of the questions of this study will be presented in 2020 at ASCO, but we focus on this presentation of the mutational status. You know, in desmoid tumor, there is 3 different mutations. Mutation on the beta-catenin, mutation 41A, mutation 45F, other mutation or no mutation. And we found absolutely no impact on the mutation status of the desmoid tumor on outcome. So the so-called S45F would be considered as a poor prognostic factors are not validated in this study. The only, in multivariate analysis, the only 2 items significant in this study is active surveillance. You see here comparing to surgery. So the active surgery, the active surveillance is the best approach in this disease. And the other parameters is the tumor size. Of course, more you have a large desmoid tumor, poor is the prognosis. And the last question on the desmoid tumor and the role of contraception or the role of pregnancy during or during or post discovery of desmoid tumor. 44 of these patients developing desmoid tumor receiving an oral estrogen contraception before, 34% at diagnosis, and 39% after, there is absolutely no relationship between hormonal contraception and event-free survival. And regarding the pregnancy, you increase the risk by 2 when you have a pregnancy in the 24 months after pregnancy. If you develop desmoid tumor in the 24 months after pregnancy, but it's not. We can propose, of course, we can propose pregnancy in patients with residual desmoid tumor, especially with active surveillance. There is absolutely no progression. The residual lesion is totally quiet. You can propose to your patient to have a pregnant. You increase only by 2 the risk of relapse, but in general, after abortion, after delivery, the tumor decrease in the same way. What about TKIs? There is 10 years ago, there is a lot of different paper on tyrosine kinase inhibitors, and now with the emergence of immunotherapy, there's less and less drugs. You have anlotinib. Anlotinib is a TKI coming from China in ASCO 2018. This randomized study comparing anlotinib versus placebo show exactly the same results of pazopanib versus placebo or regorafenib versus placebo. So not surprisingly, give exactly the same results. And in this study, it was a little phase 2 randomized trial comparing dacarbazine versus anlotinib. There is a little significant improve in terms of response and in terms of median progression-free survival with anlotinib comparing to dacarbazine. And so it was only, this study was performed only in synovial sarcoma. So maybe this trial a low registration of anlotinib, but it is not a surprise. Anlotinib is, or pazopanib or regorafenib, it's an active drug in synovial sarcoma. So comparing to dacarbazine, we are not surprised to see these results. An interesting also approach is to try to find biomarkers to select, to understand why some patients respond to pazopanib and others no. And it was made by our friend Xavier Martin Broto from the Spanish sarcoma group in 67 patients, including 2 consecutive and 2 parallel study testing pazopanib in solitary fibrotic tumor, SFT, in malignant one and typical one. All these trials have been already published. And just to share with you that there is clearly an inflammatory process in some solitary SFT. And in multivariate analysis, you see a big difference between patient having a high neutrophil lymphocyte ratio here comparing to a low neutrophil lymphocyte ratio. And it is the same finding for the red cell distribution magnitude, with a significant prognostic factor for PFS, but also an overall survival. So these findings emphasize the role of inflammatory process in advanced SFT, may be upregulated by STAT6 fusion gene, we don't know, but it's only to share with you this interesting results. A disappointing study. It is the Chordoma study and the role of regorafenib. It was the Regobon study we have running in France since a long time in 5 different cohorts, including Chordoma. You know that chordoma is very chemo-resistant disease, besides the role of imatinib, maybe cisplatin, and maybe also today we have some response with immunotherapy also. But so we have built this study in chordoma, randomization 2.1, regorafenib, usual dose versus placebo, and we found absolutely no difference in terms of non-progressive rate at 6 months, 40% in the placebo arm, 40% in the regorafenib arm. So no response at all. So it was disappointed. Same finding, of course, for median PFS and median overall survival. So I remember the study, Regobon study, include 5 different cohorts. The Osteosarcoma cohort is positive for regorafenib, positive for chondrosarcoma, negative for Ewing sarcoma, so negative for chordoma. And we are an ongoing 5th cohort in the so-called CIC rearranged cohort. And a case in point was a retrospective study we made by the French sarcoma group. We try to learn more and more in this Ewing-like 6th rearranged sarcoma. I remember you that belong to the Ewing-like sarcoma family with the translocation 4-19. Is not like Ewing in the child and teenager, more represented in adult patient, same sex ratio. And in contrast to Ewing sarcoma, the vast majority of the CIC Dukes rearranged sarcoma are arising in extra osseous parts. So here you have the translocation. So we make this retrospective analysis based on 64 patients in different centers, and we have tried. Nobody knows how we have to treat this patient. There is a cohort treating like an Ewing sarcoma, and a cohort 2 treated with like high grade soft tissue sarcoma. You see here the characteristic of patient is typically what we discover with this patient. And in the localized disease, if you treated your patient like an Ewing disease or a soft tissue sarcoma, there is absolutely no difference in all cohorts. There is a little difference in favor of Ewing sarcoma in advanced CIC Dukes 4. But for example, for me, when we treated a patient here in Gustave Roussy, I treat this patient like high grades of the sarcoma and not like an Ewing. It's maybe a mistake. We have to have more data. We have to work all together worldwide. We have to maybe define a prospective trial. Clearly, there is a space to understand what's happened in this entity. It's a very rare entity. A little phase 2 in another niche, epithelioid endothelioma, EHA. Maybe you know there is a new ESMO guidelines just published a few months ago in Annals of Oncology. We tried to define new guidelines in this unexpected, in terms of evolution, histological subtypes. The vascular sarcoma with intermediate grade of malignancy. 75% of these patients have multi-site involved at diagnosis, lung, liver, bone, and 50% of them are relatively indolent and need only an active surveillance. And we have to treat only patients with progressive EHA, and there is a rationale to use trametinib in this histological subtype because the translocation of WWTR1 and CAMTA1 overexpress the MAP kinase pathway. So an inhibition of MEK can reduce the proliferation of EHA. So there is 41 patients included in this phase 2. There is some activity. There is very few response rate in terms of disease criteria, 7%. But in progressive, if it is really the case, I don't know, because at inclusion, we have to treat only patients with progressive disease of with pain increase. For me, it's not the same disease like desmoid tumor, but we have to treat only patients with symptomatic progressive EHA. So it could be an option, trametinib, besides the different drug already used in this field, with some data with sorafenib, sirolimus, anthracycline, weekly Taxol, pazopanib, interferon. There is not a standard today, but if we try to make a large, maybe randomized trial, we have to include this kind of patient in prospective trial to better understand the biology of this tumor, but also the treatment. And to finish my talk, an interesting presentation in Intimal sarcoma. There is a high unmet need histological subtypes. We know that the vast majority of intimal sarcoma overexpress MDM2. So there is a rationale to use an inhibitor of MDM2. And Yuki Kojima reports the role of this MDM2 inhibitor, the milademetan, with from Daiichi, if I remember correctly. So we have not a lot of intimal sarcoma, but there is some really two partial response in this rare disease. So it would be an option for the future. Of course, we have to validate this data in a larger number of patients. So I think I cannot present all the data from ASCO and ESMO, but it is a selection of this presentation. I would like to thank every one of you. And of course, I can take a lot of questions.
Axel, so many thanks. It's always a tremendous work that you put in to get all together and to present it so concisely. I think you really have to commend it for that. Thanks so much.
Thank you.
I think, first of all, I would like to pass on the word to Jean-Yves. Maybe you want to comment what you heard, or just from your experience, insight, and your impressions from this year, just to highlight what the sarcoma community has to or had to progress.
Yeah, first, thank you, Axel. I think it was a really great overview. I think that what this tells us is two things. First, we definitely have to adapt the treatment to the histotype and the molecular subtypes. And the more we look at it, the more it needs further granularity. The example of leiomyosarcoma is a good example, but also the example on immunotherapy shows that probably we will have one treatment at the end of all clinical research. We'll have one or a set of specific treatment for each individual histological and molecular subtype of sarcoma, and there are 155 in latest WHO classification, so we still have a lot of work to do. The second comment is immunotherapy. I think what Axel very nicely pointed out is that immunotherapy is very much alive and kicking in sarcoma, and not at all a blank field. Obviously, we see at least 3 areas of interest immediately. Some selected histological subtypes who are good candidates, typically ASPS. some immunological subtypes across histological subtypes, which are also good candidates, typically TLS, and the questions of the cell therapy, which is really a tremendous new treatment. I mean, the first patients we treated in this center all had a massive response immediately, which seems to be long lasting for the first one of them. I mean, that's really a game changer, and that makes us quite enthusiastic for the next steps for the other sarcoma subtypes. So yeah, I think what this tells us again is treatment adapted to the histological, molecular, and immunological subtypes, and we need more and more these tools to better characterize the patients in localized and advanced phase, by the way.
Of course, that's very interesting. I was also wondering, I mean, is there anything, let's say, are there new trends regarding sequencing of, when to apply what type of treatment in terms of indication?
I think that probably what this tells us is that immune and molecular characterization should be done in the primary tumor as early as possible. And it's not a mistake to do it on the Mets, of course. But in the primary tumor, you capture the driver molecular alteration, which are shared all over the place, and that helps you to guide the treatment. Now, in terms of sequencing, that's a question which is unsolved. We used to have a very simple algorithm for sarcoma treatment, and now it's starting to be more complex with histological subtypes, but still for many sarcoma, it starts with docs containing regimen up front. This has to be worked specifically, again, histotype or histotype, but one thing we can see typically for VEGFR2 inhibitors, for immunotherapy protocol, for selected histological subtypes is that probably doxorubicin first line should be debated. But one thing which is going to be extremely challenging is that we must not wait a randomized clinical trial to do that, because we do not have enough patients worldwide. So it will be either a consensus or a new methodology decision.
What do you think regarding the value of, I mean, if you point towards the primary tumor, what is the value regarding liquid biopsies?
Liquid biopsies are extremely useful, actually, when the sufficient material cannot be found prior to the decision, the immediate decision. That's hopefully rarely the case in sarcoma. We seldom have to have a liquid biopsy to test, for instance, for MDM2 CDK4 amplification, because we have other means to suspect that this is a liposarcoma. There are some examples where we recently discussed, when I say recently, in the last 2 years, of liquid biopsies, which were just suspected GIST with difficult locations where laparotomy was not feasible for one reason or another. And in this case, looking for the primary mutation on liquid biopsy proved to be extremely useful. Because if you have a KIT canonical mutation, of course, you know that this small bowel mass is likely to be a GIST. So it's on a case-by-case basis. For most of the cases, I really guess that the primary tumor is most often large enough to do frozen material analysis or FFP.
Interesting. In how many cases you find a GIST by liquid biopsy like that? 2 or 3?
Oh yeah, in my immediate recollection is 2 patients, but I think we have 3 patients like that in the last 2 years.
So you make the diagnosis by the liquid biopsy. You can treat the patient.
Yeah, I would be more cautious than that. We started imatinib treatment on the basis of identifying KIT mutation on the liquid biopsy for a small bowel tumor. And one was not a small bowel, it was actually a tumor developed in between the pancreas and the stomach.
Try to publish this case.
Yeah, you're right. You're right. I should do that. We should do that before we have so many things to publish.
From a surgical standpoint, of course, we could bring up that we always look this, let's say, at the systemic treatment independently of surgery. Where do you foresee, let's say, the future developments, how the approach can be merged even better?
You mean not replacing surgery, but preceding surgery, right?
Yes, exactly. I mean, you know, how, I mean, let's say systemic therapy does not compensate for surgery still.
Never.
But is there anything in this direction, I mean, regarding indication?
Yeah, I think the model for this, for me at least, is really the idea of neoadjuvant treatment for locally advanced gastrointestinal stromal tumor, where you try to shrink the tumor before the surgeon can remove it. But you know that if you don't operate the tumor at a median time of 36 months probably. Well, it depends on the studies, but tumor will regrow, then you will have a problem. So you should not do that. So the model is that. So in which models do we have a look systemic treatment which is so active and specifically active for one given histological subtype that you can propose that? There are not so many. And TRAC are one of these. We had a recent interesting experience on this very question for young adults. Sadly, could not get access to larotrectinib in this patient, but that could have been a good idea. For the rest, we are really still quite limited in the treatment, which would be so active that you start with a dedicated targeted treatment or immunotherapy, and then follow by surgery. There are examples we can probably quote: inflammatory myofibroblastic tumors, PEComa with TSC mutations, a few others like that where you can propose that, but that's minority of tumors. For the rest, classical doxo or epidoxo and IFOS.
Silvia Hoff also thanks you, and she asked, how do you explain, Axel, the effects of TKI with a broader spectrum in fusion sarcoma, which normally have no further mutations? Is it all about VEGF targeting, or should we use such broad spectrum TKIs much often without a specific known target in treating the tumor?
Your question is why TKI inhibitors are active in translocation-related sarcoma?
Yeah, that's the question. Yeah, I mean, how do you explain the effects of TKI in fusion sarcoma, which normally have no further mutations?
Yeah.
Is there an explanation?
It's really the case for me in the practice clinical routine. One of the best results with pazopanib is clearly synovial sarcoma, and maybe followed by leiomyosarcoma. So, but I have absolutely no explanation. It's certainly not related to the fusion genes. It's maybe due to the VEGFR pathway, common pathway in all sarcoma in general, but I have absolutely no explanation to understand why synovial sarcoma will be more sensitive to TKI. I don't know, really.
So even neither.
That's yeah. I think that's a very important question, because if you look at the hazard ratio of pazopanib in synovial and the hazard ratio of regorafenib in Nicolas Penel's study, these are not the same. And these are two VEGFR2 inhibitors. So the only difference is a non-VEGFR2 activity, typically on RET or MET or whatever. I think this question you're asking deserves a specific examination per TKI and per histotype, because possibly in synovial you have an overexpression of say MET, HGF, RET, or whatever, and we don't know that. But that is really a research question.
Any further comments? Well, maybe we're approaching the end of the year, and maybe I would like to ask you, how do you see the future developments? I mean, what are we talking about in 1 year? Where do you think are we moving?
The future development in sarcoma in general. We want to find, first of all, we want to find an imatinib drug for each histological subtype, but not tomorrow. To maybe to best select the patient need in perioperative chemotherapy besides the surgery, so before or after surgery. It's always a burning question, and today it's impossible to answer. To understand better all the biomechanism in all histological subtypes. Each year we make efforts and we discover a new pathway in some niche. And each time we find a new pathway in rare histological subtypes, we can find a drug beside. So we have to make more and more efforts in terms of biological approach, NGS, liquid biopsy, to understand better the biology of sarcoma.
Jean-Yves, do you think, where do we have to invest?
I completely agree with Axel. I think that's definitely the first direction. Maybe another first direction is, it's simple, but that's so important. And even in our country, Switzerland, France, we need that. What we have observed is that the best way to improve sarcoma survival, sarcoma patient survival, is really to have them treated in reference centers upfront. Even though we have been working all around the telephone, I'm sure, on that in the last 20 years. In a country like France, we 60% of the patients treated, you'll see, I don't know, Axel, how many, 35, 40 with whoops operation or things like that. We move to improvement with mandatory first.
Yeah.
I'm not naive. I know that this is something very challenging at the healthcare system level, but that's definitely the progress. And the second one, if you allow me a second one, would be cell therapy with broader indication. I really am impressed by what we have. I think we are all impressed by what we have with synovial. Axel mentioned that.
Speaking about whoops, where do you think what needs to be done? I mean, it has remained constant for decades. Is there any, let's say, the experience from the French sarcoma network, which is really, at the forefront? Did that improve the whoops rate or eliminate the whoops?
We reduce the whoops rate by about 50%, but we still have a large proportion. I think the best way, what worked the best, what was the Scandinavian sarcoma group did, which was actually the states in Scandinavia, which was not reimbursing patients operated outside of reference center. Without, they reached 90%, and that's also the case for the UK, from what I understood.
Interesting. Yeah.
Not easy in our countries, right?
Yeah. There's one more question coming in. How can we make osteosarcoma hot for immunotherapy?
Axel, what would you say?
We have not made a lot of progress in the field of biology of osteosarcoma, despite the fact that osteosarcoma develop in all different populations, child, young adolescents, but also adults. Biological approach is we don't find anything, so there is no lot of targets. We make a lot of progress, of course, during the last 3 decades, since 1980, with the emergence of conventional chemotherapy. We have made an increase of response rate and survival based on the histological response, increasing the dose and of chemotherapy, but it remains conventional chemotherapy. So now we are with a plateau. Something happened with pazopanib or regorafenib, where regobone study demonstrated that even in osteosarcoma, regorafenib could be an active option. But the induction chemotherapy regimen remains the same. It's a complex disease because it's complex to include young population in prospective trial. The randomization of young patients is always a challenge for pediatrician colleagues, but also for adult patients, because for the mentality of patient, it is a curative disease. We have to cure these boys and girls. So it's complex to modify or to be ambitious in, I mean, in terms of induction treatment. It's complex to add. It's impossible to avoid chemotherapy. So the only way to move forward is to try to add something. So why not an immunotherapy? But in adjuvant situation, it's too late. You cannot see any. You can give an adjuvant treatment, whether we have made the trial with Zometa, with in adjuvant situation is complex. We have to understand better between the day one of treatment and the histological analysis to understand if we can reach the 100% of total necrosis, adding new. But we have to be ambitious. But it's complex situation due to the young population.
I think that we will not avoid the question of the combination of radiotherapy and chemotherapy plus immunotherapy to make the tumor hotter. And hopefully we'll have synergistic effects. Randomized trials are ongoing in unselected patient population with radiotherapy, by the way. Probably the same is being conducted for immunotherapy, also with VEGFR2 inhibitors with interesting results. The first thing the next thing we have to do, I guess, is to understand better the immune infiltrates in sarcoma. We see that a lot of sarcoma infiltrated not with T lymphocyte, but with macrophages, M2 macrophages, sometimes CAFs, cells where we don't know exactly what their role is, but they seem to be associated with a worse outcome in many tumors, including sarcomas, but not always. M2 macrophages and osteosarcoma is a different story. I think manipulating these could help to make a tumor which seems to be cold actually hot. And I think CD47 M2 macrophage modulators, CSF1 may be good strategies, along with a classical local injection of toll receptors or virus modified, which are being tested for the tumor types, which are, of course, good ideas as well.
So if I understand your proposition is to try to push all the cold soft tissue sarcoma to hot, injecting whatever to be more sensitive to the immunotherapy approach of other?
Yeah, maybe the hot soft tissue sarcoma. You've shown the results of the PAMBROSARC study where patients with TLS are doing much better. But at the end of the curve, they merge. So this is not what we want. What we want is a curve which is higher at the end of the curve, and we are not there yet. So maybe these tumors can work better if, and this is one of the study we are doing with a combination with a LAG3 inhibitor, for instance. But I think, yeah, making a cold tumor hot and making a hot tumor hotter.
I remember 30 years ago in breast cancer, one of our leader in France give estrogen to breast cancer to push the cells in a divided, in a proliferation way, and give more sensitivity to chemotherapy to breast cancer, but it's a concept.
Well, thanks so much. That's great. Maybe the very last question is whether you have some concluding remarks.
No, many thanks to your to be here in each month or each 2 months. We are a nice webinar organized by the Swiss sarcoma group, and thanks to the different sponsor, I think it's an important minutes. Take 1 hour every two months to try to maintain a positive action in the sarcoma community in this not easy concept of context of COVID era. So this kind of approach we have to continue to maintain the level of different sarcoma scientists and to share with you all the new data in this field. So thanks to you to push to maintain the webinar also in 2022.
I concur with Axel. I think these moments are very unique. Actually, I don't think of any other groups doing that, and I think that's always a big pleasure to discuss, because we see that we have different standpoints on the same data, and that's extremely informative. Actually, I think probably victim of your success, you may want to expand that to a broader number of countries. But we'll let you do that.
Well, that's really nice of you. Thanks so much. Having said that, I'm more than ready to go this way. I think it's just exceptional, and I thank you for your support. I thank all the sponsors for the support. Again, this webinar will be soon posted on the website Sarcoma.academy, and with this, I think there is in 2 weeks the case discussion webinar. Of course, everyone is welcome, and please register. And with this, I would like to pass on to Charlotte.